Thank you, Elsa, and thank you all for hanging in here this long. It's kind of an honor, but it's also kind of scary to be the last speaker on a program. It's like when she says, best for last, that's not likely, and it burdens me even more to think that you might expect too much. The title of this talk is Psychodynamic Perspective on BPD. I'm going to use, well, let me say one other thing. It's wonderful attending these ISSPD conferences. I've been to every one since Oslo, and there near the front of the room is a familiar face, Bjorn Osberg, who I met back then. And it is a way in which you make friends and keep them, each one of these is a chance to get together with people who become old friends alongside you, and to see the growth of the field and the changes in it, and to get all kinds of stimulation. Joel and I were just talking about how you go home filled with lots of new ideas. At this point, probably too many for me, but in any event, it's a wonderful occasion, and my thanks, personal thanks to the people here in Copenhagen who have made this conference so wonderful. So I started by saying that I'm going to use a broad definition of dynamic. In psychological world, it's usually meant to refer to the unconscious. I think in a broader sense, and the way the more generic meaning of dynamic is, it refers to the effects that latent forces have on observable phenomena. And in using that as a model, virtually any model of a treatment or even model of psychopathology becomes dynamic. This talk is divided into three parts. I'm first going to talk about the three, at least in my view, the three major models of psychopathology and psychotherapy for borderline patients, and compare and contrast them, say something about their lasting contributions and some of their problems. Then I'm going to talk about new knowledge which has been acquired since they were developed, which I feel needs to affect and alter the psychotherapy practices going forward. And I'm going to use, as an example of that, how to integrate this new knowledge into a treatment using GPM as a model for that. The three models are transference-focused psychotherapy, dialectical behavior therapy, and mentalization-based therapy. This is Otto Kernberg in 1969. He doesn't look that different now, but he was then, as he remains, someone whose fierce intelligence shines whenever you look at him. Prior to his development of transference-focused psychotherapy at that time, we all owe a debt to the contributions that came from Rorschach and Bob Knight, who identified that borderline patients before the diagnosis became very well or much used as being people whose function is highly dependent upon context. In structured setting, they look much healthier than they do in unstructured settings. And that remains a basic truth about these patients, which we all know clinically, and they deserve credit for having first introduced it. The model of borderline personality disorder introduced by Kernberg and the transference-focused psychotherapy model is one in which innate or acquired aggression disrupts the development of self and it requires the end of reality, of the sense of reality, and requires the use of primitive defenses of splitting, projection, to some extent projective identification perhaps, and that the model of therapy that is used is one in which these defenses against aggression and its intermittent and inappropriate expression get enacted with a therapist who clarifies, confronts, interprets this, and by this method brings some resolution of these conflicts about innate aggression. Amongst the lasting contributions of this model are the concept of splitting and the dramatic shifts from idealization to devaluation, the focus on conflicts about aggression and their effect on the self, that is, when the borderline patient owns their aggression, that usually is at the cost of feeling that they are a bad person, and when they project it, it is at with the idea that they then become the victims of it. Kernberg and transference-focused psychotherapy as a school of thought brought great attention to countertransference problems and reactions which are common and frequently endanger these treatments. And they offered the hope that therapists can help reconcile the dichotomous split perceptions of these patients. I went away from my introduction to transference-focused psychotherapy with the attitudes that if a patient was late, it was potentially at least a sign of resistance to treatment. And I came away from it with a model that the borderline patient had themselves developed their disorder primarily from a dysfunctional family. Some of the problems with this model: it could, and sometimes did, objectify patients insofar as the model underestimated the therapist's contributions to the psychopathology in the office. Perhaps most notable to me is the misuse, in my view, frequently of the term projective identification. As an example, a therapist may say that I found myself feeling helpless and then realized that it was because the patient had projected this onto me. Whereas as a supervisor, you might more readily see that the patient, you didn't understand the patient was getting worse on his watch, and he had good reason to feel helpless. It underestimated social learning deficits and contributions to the development of this disorder, and we'll come back to that, of course. And it was insufficiently supportive, so that there was a high level of dropouts from this approach. Finally, it depends too much on being just an individual therapy, it depends too much on the patient's disclosures. An example of this is a 23-year-old patient who was in 3 times a week psychotherapy, productively examining the relationships that she had with her family, and intermittently at least becoming angry with the therapist in a way which he found was productive material for her understanding herself. He was surprised when one day she came in and reported that she'd been kicked out of school secondary to substance abuse. When he learned this, that this was a behavior that was undermining the therapy and opposed to the contract they had formed, whereby the patient was supposed to tell the therapist about those things which were troubling in their lives, and suggested a consultation. There is much that you might like about that, but there's much that is inherently controversial about it. The next major model of treatment is that of the indomitable, larger-than-life personality before you, Marsha Linehan, dialectical behavior therapy. In this model of borderline personality disorder, emotional dysregulation combines with an invalidating environment, and through which the pre-borderline child learns maladaptive behaviors and fails to learn some of the self-regulatory skills they need, including mentalization, mindfulness. The treatment is a combination of group and individual therapy, and through these modalities, patients are improve their self-regulation, often by therapists who are themselves quite competent and can-do sorts of people, using validation, coaching, didactics, and skill-building exercises. Amongst the lasting contributions from this are that supportive real-person interventions do not, as might have been feared in the earlier generation, cause regressions, but could be helpful to these patients. There was a focus on emotional awareness and expression. The behavioral failures often prove to be skill-based and modifiable by learning and retraining. Group therapy became a valuable counterpoint and complement to the individual therapy, and so far as it both reinforced its measures and gave a social learning component to the treatment. It also introduced what's called consultation groups, which is an ongoing sort of form of case consultation, which, though they might not have at that time used the term guards against countertransference, it does do that, and at least in my community of DBT therapists, they also feel quite comfortable with the term countertransference at this point. At the end of my introduction to DBT, I came away with the feeling that if a patient was late, it may be that they have perpetually late, and it was a bad habit. It's also possible that there are problems with the transportation system, which you might help with. I came away feeling that families had been harmfully invalidating. The field had that's sort of a personal learning experience. I think the field learned a lot from this. It certainly, from these contributions in this model, evolved the studies of emotions and their regulation. Just as, and I forgot to mention this, in the aftermath of transference-focused psychotherapy and Kernberg's model, the field evolved into studying the innate aggression and the impulse aggression dimension as a psychobiological disposition for this disorder. This slide identifies some of the problems with DBT. It can be overly formulaic. Again, this isn't necessarily inherent in the treatment. It often gets that way in its usage, and that diminishes the kind of flexibility which is often one of the great assets that therapists can bring to treating borderline patients. It undervalues meanings and the role of relationships. Here I would cite as a case example a 37-year-old woman who was hospitalized after an overdose, which had followed her long-standing boyfriend telling her that he did not want to get married because he did not want to have children. While in the hospital, she cut herself, and the DBT therapist who saw her attempted a chain analysis to trace this back to its origins, and it went as far back as the disagreement she'd had with the nursing staff, which had followed a disagreement she'd had earlier in the day with other members of the patient community, and the act itself followed directly after the nurse had encouraged her to go out on a group exercise with a critical tone of voice when she didn't want to with the other patients. Well, it all made sense, except lost in that chain analysis because the patient didn't disclose it and the therapist hadn't suspected it, was a phone call she received that morning from her younger sister who announced that she was pregnant. DBT can be ahistorical and non-personologic. It underestimates aggression. Frequently, the DBT therapists are resistant or even hostile to suggestions that their patients may be remaining patients for secondary gain purposes and may willfully want to defy their therapists. The third model of treatment. I think you'll recognize these guys. They've been around here. Anthony Bateman with his, everybody's soulmate, and Peter Fonagy with his immense energy and creativity, formidable pair, and they developed the third major model of treatment, mentalization-based treatment. Mentalization-based, the theory of borderline psychopathology in MBT is that the pre-borderline child failed to learn how to identify its feelings and failed to learn how to identify feelings in others and to see the interactions of how their feeling state affects others and how others affects them. That's what's called failed mentalization. In the mentalization treatment, again, it is a individual and a group treatment where both the group and the individual therapy are laboratories in which patients are encouraged to attribute meaning or identify what they think is going on in others or in themselves, and then ask others to read that, and then check out the reality of whether they're, and to consider alternative explanations for what somebody else is doing or thinking or why they're doing it, and then to check it out by questioning it. Amongst the lasting contributions from mentalization-based treatment are that it developed from an empirical developmental base. This is the first treatment which fulfilled the long-standing promise of psychoanalysis that it was a treatment modeled after a transference based on what happened in early childhood. I think they generally gave that idea up because it didn't seem to bear any resemblance to reconstructions. But here, this was done prospectively, looking at parent-children, and a model of treatment that was devolved from that by Peter, and then Anthony implemented it and operationalized it. It is a focus on metacognition and interpersonal misattributions, and it brings, as I've already said, brings patient-therapist reactions right into the therapy, specifically emphasizing on the therapist's part not knowing and the need for the therapist for the patients to discover what's going on in themselves in the therapist and in the therapist. After my introduction, now quite lengthy introduction to mentalization-based treatment, I came away thinking that the patient who was late was an interesting problem and wondering why. And I came to believe that the parents of the pre-borderline child had failed to accurately and in a timely way identify what was going on in their child's feeling states and behaviors. Amongst the enduring contributions from this, which go beyond the clinical, is that it has evolved into and stimulated studies on social psychology and metacognition, which were much in evidence at this symposium, at this conference. Some of the problems with MBT, I guess I missed showing you that slide. You all know it. We'll go. It doesn't address aggression very satisfactorily, to my view. Aggression is secondary in this model. Second, it underestimates the value of interpretation and confrontation. And finally, the theory and the practice lack specificity. There's every reason to think that failures in mentalization are things which are found in a wide range of people who are not do not have borderline personality disorder, and the process of gaining or strengthening one's capacity to mentalize is something that may be a generic characteristic of all good therapies. How are we doing for time? Good. I'm going to move now into the, I have a case vignette here. There's a 27-year-old woman with an illustrious father who had been served a restraining order, which she subsequently disregarded, which had been obtained by her boyfriend, who was trying to distance himself from her. In response to being arrested, after being arrested for disregarding this restraining order, she overdosed and was hospitalized. All of this occurred over a period of months while she was in twice-a-week mentalization-based treatment psychotherapy and in once-weekly mentalization-based group therapy. Mentalization-based treatment has a particular appeal to intellectual people, people who are more mentalistic, and so it serves them well that Anthony is so vigilant about warning against pseudotherapies. Oftentimes, pseudotherapies are particularly likely because of the seductive and mutually pleasing exchanges which can occur in mentalization-based treatment, where they're trying to figure out what's going on in each other's mind, and it's it's very challenging and interesting. In this case, however, though, it illustrates one of the problems which can occur. In a pseudotherapy such as this, there was the therapist ignored the fairly transparent transference of a patient who saw him through the same lens as she saw her father, as somebody she was eager to please and to impress, and hence did not want to talk about those things which might displease him. And also ignored within the therapy was the fact that this is a perfectly mature, in some ways, 27-year-old woman who hadn't worked for a year while being supported by her illustrious father. Again, when I give these cases, I do not mean in any way to condemn the treatment. I'm just pointing out the common ways, in my experience, some of the more common ways in which each of these models of treatment go awry. Now, I'd like to talk a little bit about new knowledge which I think impacts and should impact how psychotherapies are conducted. Before saying goodbye to these three major treatments, though I'd like to say something about the, in retrospect, heroic struggles that the developers went through in creating and sustaining, developing interest in their treatments. All three of these treatments were developed with the ideal of the psychoanalytic paradigm as being one which they found fault with and wanted to modify. With DBT, of course, this was quite direct. It was a different paradigm altogether, behavioral paradigm that she was introducing, which was very contradictory. For the other two forms of treatment, the developers were psychoanalysts who wanted to develop treatments which would remain within the psychoanalytic umbrella and which would inform and perhaps move the psychoanalytic field along, because the psychoanalytic field was and still is very opposed to having outcome measured and being operationalized in such ways. What happened was, this is my view, the treatments they developed had little effect on psychoanalysis, except that psychoanalysis lost and became alienated from the people who might otherwise have been their natural leaders. Now, these three major areas I'd like to talk about of new knowledge. Some of you will recognize this man. He's sitting here in the audience. In 2001, Sven Tergesen reported that there was a significant, I think it was 59%, but I could be wrong. And anyway, it was quite significant level of heritability for borderline personality disorder. The only previous twin study had been done by the same person where he reported no heritability, but it was a small sample. So this was definitely an update and an upgrade on the methodology and the credibility of the result. I was at a meeting not too long after this came out, and I remember saying, 10 minutes? No. Oh. I remember saying to Otto Kernberg, I said, this changes everything. A bit hyperbolic, maybe, but it does change a lot. And I think those of us in the psychotherapy community have been slow to make the adjustments that it requires. It is, I think, this goes without saying. I think most of you would be accustomed to it. It was even inherent in something of the models that I've already discussed. It certainly The TFP model and the DBT model were quite comfortable with the idea of some, at least partly genetically determined predisposition for developing it. That was affirmed here because much of the literature about the cause of borderline personality disorder was exclusively about environmental causes. Such modeling is no longer possible. It would be unfair to patients and to their families for them to think this is a primarily psychological or determined or socially determined disorder. It would be just as unfair as to suggest that it is a biological or genetic disorder. A more complex model is needed, and any patient with this disorder and their family should be informed about this significant heritability. Just in the first place, it'll diminishes some of the family conflict, or at least puts it on a different basis right from the start. Patients need to accept that they have some kind of genetic disposition for their disorder. And all therapies should help them to adapt to learn how to formulate what that disposition is and to adapt to it. Its disappearance is unlikely. We don't know what that disposition is, and that, I think, encourages therapies using any model to remain humble that what they've got is a good hypothesis. The second major area of research which impacts treatment of borderline patients is the news about the course. This slide illustrates how frequently and dramatically borderline patients get better. None of us imagined that this was the case before the longitudinal work was done. Not shown here is that when patients do get better, borderline patients, they stay better for the most part. They do not relapse. Also not shown here is the equally bad news is that there is not a concurrent or commensurate improvement in their social adaptation. After 10 years, approximately 25 to 30%, only 25 to 30% of borderline patients will have stable partnerships or stable and satisfying work lives. Implications from that. First, all therapies should begin with the idea that they are going to take what is likely to be a natural process and facilitate it. Duration should be individualized. That is, some people get better in 6 months, some people get better in 2 years, some people get better later. The length of treatment should not be prescribed by the type of treatment that you are given. It should be based on whether and how much the patient's improving. It has become sort of a foolish rule of hand that if you're going to get DBT, you should be in a year. There's nothing magical about a year for DBT or a year and a half for MBT or anything. Those are statistical artifacts. It was the amount of time you needed with that size sample to show a statistical difference. Borderline patients, as a group, they don't wait if they're in DBT until 11 months and then hop over a threshold. They gradually get better. In all these treatments, they gradually get better, or they don't. And if they don't, it may be that you're doing God's work, but this is contrary to the statistical probability of what a borderline patient should expect. It's against the statistical probability of what you as a clinician should expect with your patient. Life's lessons are a partner in producing change. The patients in these longitudinal studies rarely had extended treatment and certainly extended treatment by people who were experts in this on borderline personality disorder, and virtually none of them in either the MSAT study or the CLIPS study had any of the evidence-based treatments. Life is a good partner. You want to help your patients learn from the lessons that they're getting outside of the office. And then finally, the social adaptation, persisting social adaptation failures require more attention. None of our existing evidence-based treatments have shown that they do much to facilitate this. Now from psychotherapy research, the third area. All three models have similar outcomes. And more interesting to me is that when they were challenged by a structured and supportive alternative treatment, they did as well, not better. The implications of that. Nonspecific and overlapping factors probably account for the changes within these therapies. And the possibility that less intensive, easier to learn models offer hopes that might be more, our forms of treatment might become, be utilized and do a service for the vast majority of patients. This slide simply says what I tried to say before about the overlapping features probably accounting for change as opposed to the differences. Let me now move to the last part of this. How are we doing for time? This last section has to do with an effort or efforts to integrate what's been learned into a new treatment, or I hope you would think of this as ways to integrate this new knowledge into all and any new treatment. I think, good psychiatric management sort of emerged as a sort of a practice which is based on stuff I'd been writing for years, and it's sort of based on clinical experience. And when we now have it manualized and try to teach it, experienced clinicians will often say, oh, that's what I do. And that's the most valuable feedback you can get, because good clinical management is something that most people can learn, and they usually learn it the hard way with lots of mistakes over a long period of time, as Paul Links and I did. But we can expedite the learning of it, and it takes and borrows from its predecessors. This is the randomized controlled trial in which it was compared with a good quality DBT, and surprisingly, I think, did as well. And this is simply a homage to the fact that it doesn't mean to conflict, it means to integrate, and show lessons learned not just from clinical experience, but from those who developed the other therapies. And here's the clinical model. Borderline patients' phenomenology is intimately connected with their perception of whether they feel cared for or not. When they feel held and cared for, you see the depressed waifs that you want to take home, and they look at you with big eyes, and they're very collaborative, and you can give these deep interpretations, and they'll say thank you. That same person who might at that point have been depressed or anxious or something else in your mind becomes borderline when you come near the end of the session, or when they're confronted by some separation in their life outside the office. This is when what Peter and Anthony call their attachment system gets activated, hyperactivated. Then the angry, self-punitive, manipulative, and devaluative features come forth. And at that point, if you didn't know before, you'll become quite comfortable with the idea that this person really has borderline personality disorder. And when they're alone, dissociation, paranoid ideas, desperate impulsive behaviors, sometimes under the disinhibiting influence of drugs and alcohol occur. This is a way to understand the changing phenomenology of borderline patients, which is extremely dynamic. It is, however, organized around a single factor, the issue of whether the borderline patient feels cared about and loved, held on to, or not. And it provides a fertile way to interpret the motives and that are, you could call them unconscious, certainly unknown. It's a fertile way, thank you, fertile way to anticipate how patients are going to react in certain situations and to problem solve and anticipate on what they might do and strategize adaptive as opposed to maladaptive responses to it. So I lost my track. And in this model, these are ways in which the new knowledge is integrated. All patients and, of course, their families, if possible, are given education about what's known about the genetics and course and are encouraged to read as much about those things as possible. Provides a frame for the treatment. It provides a frame for understanding the origins of the disorder. It is not meant, nor is it ever used as a way of exempting families from having a significant role both in the origins of the disorder and in whether the borderline person gets better or not. Rather, it puts their role as one that is less blaming and more understandable. This was a difficult child. You experienced 24/7 the same problems that we in the psychiatric profession have had with much shorter exposure and the opportunity to go home. It's an approach which builds alliances with families. At the same time, it says that how you manage what goes on with your borderline offspring can make a big difference in their future. Goals for change involve accepting and adapting to one's innate disposition. To talk about this with a patient as not knowing what that disposition is, but some of them will, because they have been in DBT, think that it's a problem of emotional dysregulation. Others will think, because they've been in a different form of therapy, that it's a failure to mentalize. Whatever it is, this is something that is a core problem which you can and we will help you improve on. But it's also a handicap that you're likely to have to learn to carry with you and always be vigilant about. Change is expected. If it isn't occurring in a treatment, the therapist should question whether the therapy, they themselves, are being helpful to the patient. Using whatever statistics you have, at this point, I would have thought that you, certainly let's say 3 months, that your frequency of self-harm should be diminished, and it troubles me that it isn't. Or if the level of psychological distress, that's not down in, let's say, 3-4 weeks. I'm troubled that that's the case. Usually, if a patient gets into an environment which is supportive, you'll see the distress go down. Things like interpersonal relations should happen over 6 months to a year, but you should have monitors of change. You should monitor in particular whether you see the patient as actively working on their problems. When you start remembering the last session better than the patient does, it's a signal. And that's in the second week, maybe even the second session. You want to make sure that the patient knows that their fate, their future, depends upon their active work on this. And you want evidence of that. If they don't remember what you talked about or they disregard it, what's going on? You make a big deal of it. It calls into question whether this therapy is helpful or whether there's something going on with you. You're very proactive about that from the first session. It's not like you wait a few months and then say, I'm not sure about this. It's something from the first day. Focus is on life outside of therapy, at least in this model. I think there are advantages of this in any model. If you have a more intensive treatment with some of the other models, it may make sense to have a focus on what's going on in the office. But for the most part, you want to keep patients focused on their life outside the office and outside of treatment. you do not want them to, you don't want to reinforce or encourage their identity as patients. You want to reinforce and encourage their identity as people in trouble who need to get back on the horse or learn how to ride a horse, but that this is a developmental step that you're there to assist them with. The goal of attaining stable partnerships and stable vocation should be supported from the beginning. I think that we talk frequently about setting short-term feasible goals. I think a discussion about the course leads them and should lead you to encourage them to hope that they might fulfill the possibilities inherent within this diagnosis of having an enriched and full life. Thank you all very much.